everything's going to kind of fall. If they've got a lot of redundant tissue in there, if they're obese, all the things that are going to increase their risk for sleep apnea, that's going to fall down and obstruct. You can overcome that obstruction by an oral airway. If that doesn't work, I would put a nasal airway in. So I might be asking for this equipment if I didn't have it on the shelf. If that doesn't work, I might then just take a view, even not having given the muscle relaxant, because I don't want to, now that I've ruled out the ability to ventilate, I don't want to then further put myself in a hole by taking away the patient's spontaneous ventilatory effort. So worst case scenario, if I can't ventilate at that point in time, what I'm most likely going to do is I'm going to get another assistant. And you guys have helped at times, you're familiar with this. The way you apply the mask, and you guys normally don't manage airways, but what we typically do is we flex the neck, extend the head, and then anteriorly displace the jaw. And if you could do that all with one hand, that's great, but sometimes it doesn't always stay. You usually see us go like this, lift up what seems like we're lifting up the head. We're really anteriorly displacing that whole jaw so that the jaw's almost subluxing and coming forward. And then we're trying to keep a finger down there at the angle of the jaw to keep it anterior. And then we've only got really 3 fingers to apply this whole seal. Well, this is really kind of like a one size fits none. It's not going to fit everybody. So there's usually some inadequate pressure that we've got around this. You know, a lot of you guys will reach up instinctively and grab the cheek and pull it down, and that's very helpful. But a lot of times what it requires is 2 hands on the airway lifting up. And you may have seen us in a scenario, usually if there's a CRNA in there, an anesthesiologist, but there might not be. It might be the middle of the night. I might say to you, hey, I need you to squeeze the bag, and then I'll get both my hands to be able to maintain the patency of their airway. I think the most effective maneuver is the anterior displacement of the mandible. So if I can get both my hands and dig my fingers under the anterior, the angle of the mandible, I can usually get a patent airway. If that doesn't work, and if you're asked to squeeze, by the way, there's a little dial on that. If you're going anywhere above 20 centimeters of water, that's the pressure that you're putting in the airway that's opening up those alveoli. If it exceeds 20 centimeters of water and you don't have a cuffed endotracheal tube in there, then there's no way that it's not going to flip off eventually you're going to overcome exceed the compliance of the lung, and it's going to flip off, and it's probably not going to come out the mouth because you got a difficult ventilation. It's not really patent this way. It's going to go down into the stomach, and you're just going to be ventilating that stomach. You'll be increasing the risk that the patient's going to vomit and aspirate, and so.
So what do you normally have that dial set at?
You're talking about the pop-off valve. I usually control the pop-off valve so that I can so it won't maintain continuous positive pressure when I'm not squeezing it, but it's tight enough to where I can generate 20 centimeters.
So it should be 20.
Should be right at 20, yeah.
Kind of what we would see.
Yeah.
Okay.
So you'd be watching the dial and you'd squeeze, and if the bag stayed empty, then you might, because I might instinctively reach over and help you, and we just kind of do it. It's just and we get to a point where we could just kind of feel it. But you may need us to, but basically what you're looking for is you want to be able to squeeze the bag, raise the chest while I'm keeping the patency of the airway, but you want then that bag to fill up again. You don't want it to stay empty, in which case, if that's the case, I need to tighten it down a little bit, or if you squeeze it and open it and it's still going like this, then you gotta
too much.
Too much. So we'll be giving you guidance for that. So now if that point you can't maintain the patency, I'd probably reach for the LMA. Everybody knows what an LMA looks like. It is basically just forming a.
I was just saying, maybe Patrick some things are labeled and some things are not in the drawers. So maybe Patrick can label.
I have a
so then if you say,
yeah.
Elements, yes, it's this
drawer.
Yeah. I'm looking for this drawer.
Yeah. No, that's good. So this has been a game changer, the LMA. It gives you patency in an airway that is kind of difficult. It gives you a hands-free airway. because you know the ABCs are really airway book chair. So
What is
Airway
it?
what?
book chair, airway
Ah,
book chair.
Book?
We want a hands-free airway. We don't want to be sitting there laboring the whole case holding an airway. Yeah. So airway book chair. We want a hands-free airway. So this has been great for all those situations that didn't really require general endotracheal, didn't require muscle relaxation because it was peripheral surgery, it was ortho surgery or something like that. In the past, if we didn't want to intubate them, we'd have to put in an oral airway and a nasal airway, and I used to kind of take that black strap and tie the things that, so that I would have a hands-free airway. This is your hands-free airway. So this is a situation where you don't need muscle relaxation, the patient is not at risk for gastric aspiration, or if it's in that difficult algorithm where I'm having trouble even with two hands and the circulator squeezing the bag, I might reach for this. And in the process, by the way, if I have realized that I'm having this much trouble and I've already kind of taken a peek to see, because at some point in time I might say, well, I need to know right now because I'm having a terrible difficulty ventilating. I can't maintain this indefinitely. I need to know right now if I can intubate the patient, because if I can't get a view right now without muscle relaxation, I'm not going forward anymore. I'm going back. So I'm going to turn the gas off. I'm going to get this patient awake, and we're going to start all over again. So you preserve an escape route. So this is going to form a little cuff around the trachea in the back of the mouth. So it's gonna help you if you've now got it's gonna open up the patency of a patient who, if they're spontaneously ventilating, they will start now to be able to pull atmospheric air in there, or your oxygen, your inspired gas. If I have to ventilate, it's gonna really be just that 20 centimeter threshold again. If I go anywhere above 20 centimeters, it's gonna pop off around this thing. Because this is not really a seal that's going to apply itself that firmly, and it's going to end up ventilating the stomach. So this is not going to be my definitive airway, but it can get you out of a situation if it's difficult. If it's just like, well, at least I can ventilate the patient. If I needed this just to be able to establish ventilation, and I already demonstrated to myself that I didn't have a good view, I'd keep moving backwards. I'd get out of this situation. I'd wake the patient up. We just approach that airway now as an awake fiber optic intubation. So let's just assume that this doesn't work. We've basically got a desaturating patient. We've got to intubate now. This is why even with, you can see that if our intention wasn't to intubate, now it needs to be intubation because we can't establish any airway for positive pressure ventilation. We can't really move forward. That patient's not just going to spontaneously get better. It's just going to get worse. So, even a MAC, even in endo, Regan ends up giving 100 of Versed, and the patient's finally motionless, but they're also completely apneic. You're going to have to intubate that patient. Basically, the two blades that you might see us ask for are the curved. The rationale of the curved is it's supposed to go into the airway, grab on top or superior to the epiglottis, and as you lift, the epiglottis is going to be under, and it's going to lift up as you give force along the axis in the handle. And so the Miller blade is basically
What's that one called again? That's a Mac.
This is a Macintosh. Yeah, we call it Mac for short. And there's always a rivalry. Everybody was either trained on a Mac or a Miller, and you're supposed to be, able to be facile at both, but usually everybody's better at one. And of course, Mac is the right blade, but and this is the wrong blade. But the people that use this wouldn't agree with that. But this catches the epiglottis, and it lifts it up. So you can conceivably maybe get a better view in a situation where the patient's really anterior. The problem is you can see how narrow it is. It doesn't do very much in terms of moving everything out of your way. And the other thing is that, it's so narrow that it catches the epiglottis, but the epiglottis is constantly flopping down. So you see, you can notice, you just kind of keep an eye on this just out of curiosity. The CRNAs are going to be struggling with this more than you see them struggle. This is smooth as silk. You put it in, you bang against the vallecula on top of it, and you lift up, boom. You either see it or you don't. But this, they're going to be going, they're going to be like this, and they always struggle with this. That's why it's the bad blade. So anyway, so you're trying to get a view. Now, you might be asked to give cricoid pressure. Now, when we ask you to give cricoid pressure, it's going to be for one of two reasons. One is going to be because the patient is at risk for gastric aspiration, and you're trying to help with a rapid sequence induction, in which case you need to leave that cricoid pressure on until we say you can let go now. If we're just asking for cricoid pressure because we need somebody to push that trachea posteriorly so it can come into the view, then it's not any big deal. It's not gastric aspiration that we're concerned
So
about.
is everybody familiar with where to press for a
Yeah, I was going to go into that.
pressure?
Yeah.
Perfect.
Okay, so
All
if we
right.
ask you, if we ask you to give us cricoid pressure and we see you coming like this, well, that's not right. If you try to do this, and I've seen people do this, you need to come at it like this. Your pads together, because you're basically making a little thing here. So if you reach up, and you're the only one that's going to have an Adam's apple. The Adam's apple is really where the two halves of the thyroid cartilage come together. So you can go to the bottom of the thyroid cartilage, and then you feel another big ring under the thyroid cartilage. So between the thyroid cartilage and the cricoid cartilage. Can you feel the cricoid cartilage? Because it really kind of goes around the back of your neck. Okay, so just go right above the cricoid cartilage. There's like a little flat area where you can kind of rest before you go up the thyroid. Okay, that little membrane there is just a membrane. So there's nothing between your finger and the trachea except for soft tissue. So that's where we want you to put your little narrow thing on that, feel that, get it there, and just push backwards. Okay, so it doesn't have to be really, really aggressive, because the fact is you're just trying to basically occlude the esophagus, which isn't behind the trachea.
Do you want us to be more aggressive if we're holding for gastric?
You're not going to be able to. You're only trying to stop passive regurgitation. So, and it's going to probably at some point it's going to deviate. I have the tendency to be able to, get a little bit if I'm helping. Give malignant cricoid pressure, in which case then somebody will say, I don't see anything, and then I'll go, oh, and I'll ease up a little bit, and I'll go, oh, okay, now I see everything, because I basically kind of twisted the, So so gentle pressure down, and you just kind of hold that. You're basically just trying to keep passive regurgitation from coming up into the airway. Okay, so what else? Incidentally, that's the membrane that we're going to go through if we can't get an airway. There's going to be a couple of things that we do. There are, I happened to open the store and I forgot that we had these things. You guys ever seen this? It's an LMA with a shoehorn. It's called a fast track LMA. It's basically this, only it's a shorter shaft. So you can get a patented LMA tube to go through this and then into the trachea. What's that?
Sorry, I was whispering to her now.
That's okay. So this is, and you can use the LMA if you're in a situation where you get some ventilation with the LMA and you need a definitive airway. So let's say it's the patient that I'm just in the L&D suite that I'm thinking she's going to aspirate any day now. I know at least she's not anoxic, at least she's not dead, and at least the baby's alive. But who knows what's going to happen before they close this case up. I might want to say if I've got one of these in already. I could still use this in the same way that I would use this. I just really need a fiber optic scope. So I'd take a tube, not this tube. I'd just take a regular tube. I'd sheath it on the fiber optic, and then I'd go through the fiber optic through this, and then when I looked at the cords, I'd just jam the tube into the cords. Because when you put your fiber optic scope out here, if you've got a good seal, you're going to be looking right at cords.
That will fit through that?
Not a 3. You need a 5. A 7.5 will go through a 5. A 7 will go through a... No, this is not a fiber optic. This is the glide scope. So the glide scope would be something that I probably would have reached for before I reached for, certainly,
Someone asked when we get the fiber optic, what would I get?
The fiber optic, you'd bring this thing in.
That's correct.
Yeah. And you've seen it, the ENTs use it, it's the same thing. It's a flexible fiber optic scope.
It's good
And
just
so-
to bring the whole carton of it.
So
Yeah.
are you able to intubate through your disposable rings, LMAs? You had to change it out?
Yeah, if I had to. I mean, important thing to realize is that the dumbest airway is smarter than the smartest anesthesiologist. So you basically, nothing's gonna be 100%, not this. In fact, I think that the downside of this, the only downside, because it is a great instrument, is that it's given us lulled us into a false sense of security, because it's basically taking all those patients that we would say, like, there's no way I'm putting this patient to sleep until I've got an airway. Whereas you say you have this and you think like, well, I'll put them to sleep, but I'm sure I could see it with the GlideScope. So you're taking known difficult airway patients and you're saying, I'm putting all my faith in this. I'm not gonna do that. If they've had if they've really got some difficult air, I'm gonna wait and do a fiber optic intubation. Basically this thing, the only thing that this is really doing is it's giving you so this view is gonna give you a direct view. You've got to get everything out of the way so that your eyes can see the vocal cords. And if you can't do that, then the only thing that this offers above that is that it's angled up so that the camera gives you a 30-degree view. So the problem is with this is that you get great views, but it doesn't necessarily mean that you're going to get the tube in, which is why it comes with a rigid stylet, which now the literature is showing horrible palatal injuries as a result of the use of these things. They're just like, perforating the palate, horrible damage. So you got to be really careful about this. We've been instructed now to kind of maybe insert the tube with it so that at least you're watching and you're not happy with a nice view here and this thing's going, all over, and you don't know where this thing is because you can't see it until it gets into that view. So if you can't, and then sometimes you get it into the view, but you just can't make it no matter what you do, go through that tube. Because a lot of times, it's so anterior that if you get up there, you can't, now you're going straight up, and you can't really make it go back down again. And so it's not perfect. Okay, so I might ask in that situation, I think, me and you did one case where we took like an hour to intubate Quayer's patient. We finally got it. So a lot of times I'll do this. I don't think many of my partners have done this, but I've done it like about a dozen times. I'll ask for a CVP kit, and then I'll get this out of it, and then I'll get this angiocath out of it. Let's see, this is the smaller IV kit. I'll get some sort of introducer, and I'll go back to the cricothyroid membrane, and I'll just jam this through the cricothyroid membrane. I'll point at cephalad. I'll take the wire. I'll thread the wire. I'll wait till the wire's like about here, because you're working with kind of a short wire in this. It's not, if you have a urology wire, it's even better. The problem is that this is short, you don't have a lot to work with, but I'll thread it so that it's just out of the neck here. And I'll take that, the introducer needle out so I'm not causing too much trauma. This usually ends up either spontaneously coming out through the mouth or coiled in the back of the pharynx. You can open the mouth and usually fish it out with this.
So you're inserting it from here, going in.
Right, so I basically got a laryngeal flossing was performed in the usual fashion. So this thing is coming out the mouth, so I've got the two ends. Now the problem is you got to get the tube over it, and so what you need to do is, if you've got a urology wire, that's great because you can go the whole length of the tube. But you usually don't if you just grab a CVP kit. So what you need to do is you need to put it through the Murphy eye here. There's a little Murphy eye. It's designed so that if you get too far deep and you're up against the carina, at least you got a hole over the other side. It kind of minimizes the likelihood of what do we usually say when it's just one side? Main stem intubation. So this is gliding on a scope. So if I've got this end in the mouth, and I've got, let's see, I wouldn't be doing that. I'd be going through the neck. It'd be like this. And so I get somebody to hold this end, and I hold this end, and I try to get it to go along the wire. Now, that's called a retrograde intubation. And it works, it seems like it will work all the time. But again, it's not 100%, nothing is. So the main problem with this one is that you get into the trachea with this, but once you let go of this end so that you can, because you're gonna have to let go of one end or the other, because you can't
Leave it.
You can't leave it, obviously. The problem is that when you start pushing, it's gonna drag the whole apparatus, the wire and the tube, it's gonna flip off into the esophagus. So it doesn't always work. In fact, it didn't work in that one, because I used, I don't know if you remember, but, okay.
I know I've done other intubation stuff with you before, but.
Yeah. So most of these interventions that I've just mentioned are gonna presuppose that you're able to at least eke by some, because, you know, if I was running after this stuff and I was in a true can't intubate, can't ventilate situation, I've really only got about, 4 minutes tops. And that's in the best situation where I've got a skinny patient who's adequately pre-oxygenated. There's a couple things that I can, well, there's really only, if there's an ENT in the room or a surgeon in the room, I could say, I need a surgical airway. Look at a scalpel, they'll open the neck, they'll jam a trach tube in. This is called a cricothyroid set. I've never actually opened one of these, and I hope I never do, because I don't really want to, mangle an airway. But if I had to, I would. The other thing that I might do is that if I was able to find the cricothyroid membrane easily, and I could, in a pinch, take a 16 gauge angiocath, shove it in there, and I have this thing in my briefcase. It's just low compliance tubing. I've had it for 24 years now. It's so that, and I never use it. So it has a little tube connector. So it has an ability to be able to interface with the machine. So it has this on one end, and on the other end it has a lure lock. So so I can hook that to the fresh gas outlet on the machine, lure lock it into a 16 gauge angiocath through the neck. I'm not pointing up this time, I'm pointing down this time, but I could still get that catheter in there. And I could do either jet ventilation or ventilation with the machine itself by holding the flush valve. It has a high risk of barotrauma, so you gotta be careful. You gotta push the button or squeeze the jet ventilation thing. The jet ventilator has a lure lock, so you just pull, I think we have it in the room. We have attachment here. So we pull it out, attach it to the oxygen, and it's got a lure lock. It's got a little handle that you squeeze. I don't know if you ever use an air compressor.
Yeah, we did.
Yeah. You just, and you gotta make sure that once you see the chest rise, you immediately let it go. Problem is that if you have had problems ventilating, then you got good air inflation, but you're still having problems getting that air out because you don't have a patent airway. You got to give time for it to expire as well. You're gonna get gradually auto peep and then blow along. So what else? So yeah, so the cricoid, this is basically just a wire technique. So that if I, and it's basically just a progressive dilation. You can see some of these ugly dilators right here. You just keep dilating it up so that eventually on the last dilation, you've actually got the trach tube on it. And you just jam the whole thing in and then pull the dilator out.
That has everything in it, right? If you have to,
Mm-hmm.
you don't have to go
Yeah.
for everything else, because I remember doing that.
Right. Yeah.
No,
You did that?
in the case.
In
I
the
was in the case
Yeah.
when it was a long time ago.
Yeah.
It was an emergency, we had to do it.
Yeah.
I can't remember.
That's pretty far
Everything
down.
is too, they have it up in ICU,
Toby
or
or
they
one
may
of the
call you
ENT
if they've
guys.
used theirs.
Yeah,
Because
yeah.
I've had that.
Yeah, so just remember that as soon as I've used all this, hopefully it's had a happy ending and the patient didn't die. There might be another patient going in another room in 2 minutes that might need all this stuff again. So we gotta make sure Patrick either replenishes it or we at least replug this in. The fiber optic scope, I didn't really talk about topicalization. I don't know how we're doing on time, but I'm probably exceeding my time.
Wait, it
But,
needs to be plugged in?
this needs to be plugged in. There's a plug in the, this lives in the OR and OB, and it lives, there's one in OB, and then there's one in Patrick's office. And so it's plugged in and it plugs in right here. There's a,
You don't have to plug it in when you use it though.
No.
No, I know to charge it.
Yeah, to charge
the charger's laying on the floor over by the syringe pumps. As you walk in the door, it's kind of in the back left, and it's laying on the floor. You just pick it up, and you'll recognize the one that has typical like PlayStation logo. Yeah.
I find it almost every weekend unplugged. And it's like-
So so you'll only really be asked to retrieve this cart, this, This usually sits on this cart. Didn't get to talk about topicalization, but an awake fiber optic airway is something that I used to do all the time. It's a situation that preserves the patient's spontaneous ventilation until you've established a definitive airway. And then now it sounds, it's a hard sell to the patient. You got to say, okay, you're really not going to be that awake. You're going to be obtunded. And I always tell them, I've done a lot of airway awake intubations, never had anybody remember what's actually going on, that they seem conscious at the beginning. And I had some surgeon say one time, he goes, yeah, but I'll remember. Yeah.
So about a bougie,
Yeah.
can we discuss about a bougie, where that is and
Yeah,
how that's
so
used,
this
how
is,
it's
this is not the bougie here, it's on top, but it looks very much like this. It's a little bit thinner than this. And
We
it's,
don't have one on the side?
this is not our anesthesia cart, this is our
Oh.
difficult airway cart.
Right.
But every
They
one of
don't
our
have-
anesthesia
Oh,
carts
yeah,
have it,
right.
yeah. And they're usually clipped here or
Yes.
taped, yeah. Or sometimes they're, there's a little ridge above the machine
Okay.
that fits through. And so, and one of these days I'm gonna invite the president of that company to come in. I'm gonna say, okay, I need one of those now. And I'm gonna time how long it takes them to get that thing out of that package.
Right.
Yeah.
Did you have a question or you just
No,
stretching?
sorry,
So is there's a proper way to help y'all put it in?
No, not really.
Not really?
Just hand us
Just
to
hand it
it
to
with
you?
the little bent end. We're gonna choke up on that end, and then we're gonna thread it.
Okay.
And then you can take the stylet if you want to be helpful. You can take the stylet that we have in the tube, because most likely we started with a stylated tube,
Right.
so that this can just kind of go over it. There might be a point in time where we get to this point, and we need to keep going like this, but we don't want to drag the bougie in. So we might get you to pinch right here, so that you could hold it still. Yeah.
Perfect.
And what else would you guys be asked to do? You might be asked to assist in the topicalization. If you spend if you spend 5 minutes on topicalization and sedation, if you spend 20 minutes on topicalization and sedation, it's going to take you just 2 minutes to put the tube in. Anybody see me doing awake fiber optic before?
Yeah,
I
quite a
get them
bit.
in. Yeah, sometimes I could do it pretty
You do it
smoothly.
quite
So. Because it's all because I spent a lot of time topicalizing the patient. Usually a nebulized lidocaine will pretty much topicalize all the upper airway. I additionally add a transtracheal block, so you'll see me go to the cricothyroid membrane again. I'll take a syringe, I'll poke it through, I'll thread the syringe, or thread the catheter, take it off, I'll inject the 2 cc's through the flexible catheter so that when they cough, a needle doesn't go through the back of their trachea. And it just coats anesthetizes the bottom of their cords, and that's going to be the most effective topical block, so that you can see me maybe twisting this tube trying to get it in, and the patient's still kind of awake and he's got his eyes open and he doesn't seem to be bothered by the fact that I'm grinding a endotracheal tube through his vocal cords. So
What's the top, like,
Jen, can you go relieve
not
Latoya?
reason, but what,
Thank you.
what would we think you'd have to do an awake intubation for?
Beth,
You
If-
know what I mean? Like,
yeah.
what's the
can you go
top,
relieve Jen Trice?
if I
scenario like?
probably like an
Doing like
airway
an
tumor,
unexpected-
airway tumor.
Will you relieve Jen
Yeah,
Trice?
because most
OR3. Thank you.
my threshold for doing an awake intubation used to be, I'd end up doing one a month. If I expected any problems with intubation, and I'd say, I want to, especially if the patient was also at risk for gastric aspiration, because then I think, if I futz around with the airway and I can't get it in a rapid sequence, this patient's going to aspirate. So, and my threshold was really low. But now with this is why I was saying this is a huge temptation. It's like, I'll get them off to sleep, and then I'll take a look at this. I'm sure I'll be able to get it in this. So this is basically kind of taken away 90%, 95% of the situations where I would have otherwise said awake intubation. But now, if it's it's a large tongue tumor or a head and neck disaster, or if there's radiation to the neck, if they have radiation to the neck, you can put a blade in, and the difference between you just putting the blade in their mouth and you exerting just atomic strength in this direction, the view is going to be exactly the same. You can't make anything move in radiation. So that situation may be one where I say we're just going right to the awake. And then it's just judicious sedation and topicalization to facilitate. Because if you do that, then you just take a couple minutes. If you just do a couple of minutes of topicalization, it's gonna take you all day to put the awake intubation in. People are gonna struggle, and it's gonna be ugly. Any particular questions? Yeah.
I missed the part about the bougies. What does the bougie do?
The bougie just provides a stiffer, because sometimes you can see the vocal cords, but you can't get the tube to go to where your eye is seeing. The tube being
Also called
smaller.
Eshman, right?
Yeah, the Eshman is,
Where are those?
those are the ones that are taped to the, our anesthesia carts in the room. And sometimes there's a little strip along the ridge of the anesthesia machine, just above, at eye level. It's a blue lump.
Well, that's if they're gonna dilate. You're thinking of the dilation.
Yeah, that's why it's really not a bougie. It's really an Eshman
It's
catheter.
Eshman.
Yeah.
It's a blue.
It's a blue and it comes in a
Show them that.
Yeah, it looks kind of like this, but this is not it. This is actually, this is what's called a Cook intubating, it's an Aintree, so this is an intubating stylet. So I can put a fiber optic through this, and then I can get my fiber optic in, because I can manipulate the fiber optic, I can get it into the trachea. Well now, just because I got it into the trachea, doesn't mean if I've loaded a tube on that doesn't necessarily mean the tube's gonna go exactly where the fiber optic is. It might get hung up on the trachea. So if I do this, I can get this in a lot easier. And then once this is in, I can just take the fiber optic out, and I've got a huge stylet that's now in the trachea. And I could do one of two things. It's a lot bigger, so my likelihood of getting a tube to go over this and follow it into the trachea is gonna be higher. The other thing is that if I can't, I can hook this thing up to the end of it. It's actually got a lumen big enough for me to ventilate through. Now it's gonna be crappy ventilation because you don't have a seal, but you can do it.
And where are extras? If we use one in a case, I'm sure Patrick would restock it
Yeah.
on the anesthesia cart. But I guess he has them stocked there in his anesthesia.
I think he's got some in the cart, but I can't remember. Yeah,
Okay.
you'll just have to
Follow up with him.
yeah, I'd have to do what I do, which is basically look in the cart. If I can't find it there, look in the office. If I can't find it there, I call Patrick.
Yeah.
Yeah.
He has a lot of things of bougies there, Eshman. As you walk in on the left-hand side, there's like a dry erase board,
Uh-huh.
and then there's like a silver tray, you know, that's on it.
Oh, okay.
There.
They're one-time use, so. Yeah.
Right.
So that means you're all objective? Did we cover?
Yes, it covered everything on here.
Uh-huh.
So on your
Anything else?
sheet,